Hey there, health enthusiasts. Welcome back to our channel. Today, we're unraveling the secrets of giant cell arteritis, or temporal arteritis. But before we dive in, make sure you hit that subscribe button, ring the notification bell, and join our ever-growing community of health-conscious individuals. Ready? Let's go. Giant cell arteritis, also called temporal arteritis, arteritis cranialis, Horton disease, granulomatous arteritis, or arteritis of the aged, is a systemic inflammatory vasculitis of unknown etiology. Most common form of systemic vasculitis in adults. Classified as a large vessel vasculitis, but typically also involves medium and small arteries, particularly the superficial temporal arteries. Also affects the interorbital branches, especially the posterior ciliary and ophthalmic arteries, occipital, vertebral, and proximal vertebral arteries. Can also affect the aorta and the carotid, subclavian, and iliac arteries. A close relationship exists between giant cell arteritis and polymyalgia rheumatica. The average onset age is 75 years old, with incidence increasing passing the age 50. Mostly impacts whites, especially those who are descended from Northern Europe. Women experience it more frequently than men do. The onset of clinical features may be either abrupt or insidious. They can begin with constitutional features such as anorexia, fever, malaise, myalgia, night sweats, and weight loss. Headache is usually localized to the temporal or occipital area, and occasionally it is diffuse. Also with focal tenderness. Jaw claudication, which is discomfort during chewing of firm foods or prolonged speaking. Due to ischemia of the maxillary artery supplying the masseter muscles. There can be tongue infarction also. Ophthalmic complications are common and include visual disturbances, amaurosis fugax, diplopia, transient repeated episodes of blurred vision, and blindness, which occurs abruptly and painlessly. The most common cause of vision loss in GCA is anterior ischemic optic neuropathy. This results from ischemia of the optic nerve head, which is supplied mainly by the posterior ciliary arteries. The nervous system can present as mononeuritis or polyneuropathy, acute confusional states or coma, acute encephalopathy, transient ischemic attacks or strokes. Rare but serious complications of coronary arteritis can result in myocardial infarction or visceral organ ischemia. If ascending aorta is affected, it can lead to aortic rupture. Features elicited during examination depend on the organ system's vessels that are damaged. Superficial temporal artery, erythema, tenderness on palpation, nodularity, thickening, or reduced pulsation. The carotid artery, if affected, shows tenderness, also called carotidynia. Carotid bruits can occur and are frequently bilateral. Also, axillary and brachial arteries should be assessed for bruits also. All patients must undergo a complete eye examination. The anterior ischemic optic neuropathy during ophthalmoscopy can show sludging of blood in retinal arterioles. Optic disc may show chalky white pallor and edema, with or without splinter hemorrhages along the disc margin. Edema resolves within 2 to 4 weeks, it is replaced by optic atrophy. Other vascular ophthalmic presentations include posterior ischemic or retrobulbar optic neuropathy presenting as optic pallor and atrophy in fundoscopy. Central retinal artery occlusion in fundoscopy is pallor and diffuse retinal edema with a cherry red spot. Branch retinal artery occlusion. Choroidal ischemia. When investigating a patient, the European League Against Rheumatism guidelines state that in suspected cases, early imaging is recommended. Patients with high clinical suspicion and a positive imaging study can be diagnosed without biopsy or further imaging. For patients with predominantly cranial manifestations, temporal artery ultrasound is recommended as the first imaging modality, which shows a halo sign. MRI can be used if no ultrasound. For extracranial arteries, US, PET, MRI, and/or CT can be used. Laboratory values, elevation in the erythrocyte sedimentation rate and C-reactive protein level. A normal ESR does not rule out the disease. CBC reveals mild normochromic normocytic anemia and thrombocytosis. Superficial temporal artery biopsy should be performed as soon as possible. A positive biopsy is diagnostic. Color duplex ultrasonography of the temporal artery shows a hypoechoic halo around the temporal artery lumen on color duplex sonograms. Aortic arch and cerebral angiography may show occlusion. CT and MRI demonstrate multiple areas of infarction of the brain. The American College of Rheumatology presented a classification criteria for giant cell arteritis. Age 50 years or older. New onset localized headache or localized head pain. Temporal artery tenderness to palpation or decreased pulsation. ESR of 50 mm per hour or higher. Positive arterial biopsy results, vasculitis characterized by mononuclear infiltration or granulomatous inflammation, usually with multinucleated giant cells. The presence of 3 or more criteria gives a good diagnostic yield. In management, high-dose corticosteroid therapy should be started as soon as possible to prevent blindness and other potentially irreversible ischemic sequelae until symptoms resolve and ESR drops. Then taper down to the lowest dose. Additional steroid prophylactic treatment needs to be provided, including low-dose aspirin, proton pump inhibitor, bisphosphonate, calcium, and vitamin D. Monitor for the steroid-related complications of diabetes mellitus, hypertension, peripheral edema, and weight gain. In steroid-resistant cases, drugs such as tocilizumab, cyclosporin, azathioprine, or methotrexate may be used as steroid-sparing agents. As we wrap up today's exploration of giant cell arteritis, I hope you've gained valuable insights into this complex condition. If you found this video helpful, give it a thumbs up, share it with others, and don't forget to subscribe for more engaging content on various medical topics. Thank you for joining me today. Until next time, take care and stay well.